Thank you very much. I would now like to have Dr. O'Donnell up to the podium to moderate our Day 2 panel discussion, as well as the rest of our panelists.
All right. Can you hear me? Oh, yes.
This is a question for Dr. Shastri. I'm sorry, I'm going to qualify this that I'm not a oncologist. But have you ever treated radiation-induced MDS? Not XRT, but radiation toxicity, MDS.
That's an interesting question. I don't believe so, no. I mean, are you talking about like natural disasters that have induced?
Not really. You know, there's new infusible radiation therapy, and one of the complications is essentially what looks like low-grade MDS. And I was just curious if you've ever seen that before.
That's a good question. I have actually not clinically seen it, but I do work with somebody, a researcher who's a radiation oncologist, who studies this topic extensively and is looking at TPO-mimetics, you know, kind of targeting this area. So I haven't seen a patient clinically, so no.
Okay.
Yeah.
Or have any of the other hematologists seen it?
So remember, there used to be these radioisotope antibodies for lymphoma. I can't remember what they're called right now, but they used to start at CD20 and they had yttrium and stuff like that. So we did have a few patients back then who would come with bone marrow failure, MDS. They were often at complex karyotype. Even if they hadn't had MDS completely, they used to come with some cytopenias. We would watch them. Eventually, they'd evolve into MDS. I don't know what the names of those were, but
Yeah, so I agree with Dr. Kadia. I have seen patients with like having bone marrow failure, but more in the realm of aplastic anemia or hypoplastic MDS, but not like low actual MDS or, you know, yeah.
But why do you ask? Do you have a specific question? Or?
Well, the reason I ask is, you know, we have this new treatment called Radiotherapyinduced in this different field called neuroendocrine tumors. And what we do is we inject a somatostatin analog attached to it. And so, as with all your chemos, you see a depression of bone marrow function, and then it usually comes back, except in some people it doesn't come back. And we have very, very few cases, thankfully, in which they do progress to leukemia.
Yeah.
And so I was trying to understand, I mean, the only reason I'm sitting here is because I'm trying to understand this exact thing for this toxicity, for this therapy that we give.
So I think it's there. I think that's because I came up with. Do you remember what the radioisotope ones were? They were like.
Well, yeah. So it used to give Zevalin and stuff like that,
right,
which
yeah.
was Y90.
Vexar and Zevalin, right?
Yeah, Vexar and Zevalin, yeah, which are a little bit.
So those I did have people with MDS with chromosome abnormalities and AML. Those patients. It's not uncommon. So
it's not uncommon. I mean, the problem is the radioisotope falls off, goes into the bone marrow, gets stuck in the bone because it's a heavy metal, and then it continually irradiates it.
Yeah.
And so some people get it. I don't know why, and I can't predict who. And it's independent of chemo exposure and stuff like that. But I was just wondering, so it sounds like they do have cytogenetic things.
This was back, but way back, yeah.
Yeah.
Dr.
What's the incidence you're seeing? What's the incidence you're seeing?
It's pretty low. The MDS, I mean, usually what they do is they kind of have a general, like, aplastic anemia kind of thing. It's a suppression, but that I can't give the therapy anymore because their platelets are like 60.
And the baseline counts are fine?
The baseline counts are fine. Now, it's induced by the therapy. That's why I was curious just to see. Because the things she described are essentially kind of neoplastic, it seems like, which is different from what I was hoping to see. But I was just curious.
So congrats to all of you. I think the talks today were really fantastic. Each of you, I think, really took on really complicated topics and handled them well. So one comment to Dr. Shastri, I think, on MDS, and I just want to make it clear to the audience about allotransplant. We probably shouldn't have any slides that say donor or no donor, because I mean that was actually a major issue, especially for patients of mixed ethnicity. But we have really exciting data that are now have 3-year follow-up, but relatively recently had 1-year follow-up with mismatch unrelated donors with the allogeneic transplant registry. With really I think the 15 MMUD study had 79% overall survival and 72% 1-year survival with patients who had 1 to 4 antigen mismatches. So just only for the audience, and I know you know this, but just throwing out there, everybody has a donor, and because we don't need matched donors in the family or even in the registry anymore. And so I think that that's not to say everyone should get a transplant, of course, but but donor availability is really a non-issue finally, which is a great thing. So Tap, I actually wanted to ask you about, a thing that you had so much to cover, but one thing obviously conspicuously absent from your future roadmap was, all cellular therapies, right? And I'm just, are we at the point where beyond obviously the breakthroughs with Vistagen, Leclocel, and ALL, and obviously we have obviously an approval in adult ALL as well, but are we at an impasse? I mean, what about NK cell therapies, or obviously people, have been working pretty, I think, with a lot of futility on AML cellular therapies, and just wanted to just get you to comment on that since we have an opportunity.
So that's great. Thanks. I had to cut out a lot of things to kind of, I could have done a whole ALL talk, and half of it would have been on CAR T cells. I think in ALL, acute lymphoblastic leukemia, the CD19 CARs and now the CD22 CARs have shown remarkable activity in patients. I think the question there is going to be, are these CAR T cells merely a bridge to allogeneic stem cell transplant ALL, or are they going to be a persistent therapy that you can continue on? And what we're seeing more and more is that the persistence of these cells start to go down. I think technologies need to be innovated in order how to extend that persistence so that those CAR T cells, those engineered cells, can then be the sort of the allogeneic transplant to keep these people in remission. On the AML side, unfortunately, the outlook is currently not great, right? So we've tried several different types of cellular therapy, CD123 directed, CD33 directed. There are some bispecifics. There are NK cells, NK engagers, which look very promising. These are sort of monoclonal antibodies which have a tri-specific motif where they connect to an NK cell, they activate the NK cell, and they connect to either CD123 or CD33. There were DARTs in development that came and went. So I think that AML seems to be a little bit more challenging in terms of what is the right cell that is needed or that's active against AML, and what is the right target. Unlike ALL with CD19 and 22, AML, the 123 seems to cause complete marrow ablation, you need stem cell transplant. 33 is heterogeneously expressed. We had we were positive for a while with CLL1, and that it doesn't seem to be the one to treat. People are now trying sort of just NK cell bulk infusions, where they're just giving non-specific NK cells with the hope that it will overwhelm the leukemia cells. So a lot of different things are happening. I wouldn't say anything has yet panned out as promising where I would say this is going to be the next thing, but there's a lot of activity there. Yeah.
Other questions from the audience?
Sorry, this might show a little bit of the fact that I don't practice in leukemia as much as the other heme malignancies, but do we have an ideal way of handling the antifungals with venetoclax? Is there like a consensus on the best antifungal to do when someone's on venetoclax, or are we still mostly practicing on an institution by institution basis?
Yeah. That's a good question. So we've actually done some close research on this. It hasn't been published yet, but I'll tell you about it. So we took a bunch of people on the CLAD-LDAC-VEN study who were getting azoles, not azoles, et cetera. We did actually venetoclax levels. And people who were getting no azoles, their venetoclax levels were perfect. They were where we expect in the PK studies. People who had voriconazole, their venetoclax levels went up. But if we reduced the dose, their levels matched what we expect with single-agent venetoclax without azoles, just a little bit higher. When we gave posaconazole, the levels of venetoclax were astronomical, like boom. And so back then we were using 100 of venetoclax with posa. We dropped to 70. We dropped to 50. 50 milligrams of venetoclax with posa seems to be what brings that level of venetoclax down to what we see with voriconazole without any of the azoles. So posa is a very potent CYP3A inhibitor. It may also have some transporter function that actually brings the ven levels very high. And what you also notice is that the clearance. And so normally you see ven, you give the ven, you're off the ven, and you see like by the end of the cycle, there's no ven detectable. In the posa patients, there was ven detectable. So that tells us that, hey, so then when we started cycle 2 with more ven, their peaks were even higher, their Cmax. And so I think that the ideal, what I do is during cycle 1, since they're inpatient the whole time, I don't give any azoles. I give echinocandin, either caspofungin or inidilofungin, something like that. Just keep it clean, 400 milligrams. As they go outpatient, I typically use voriconazole with 100 milligrams of venetoclax. If I'm going to use POSA, we're actually starting to drop it to 50 milligrams of venetoclax.
What about isavuconazonium?
ISA, again, so there we had some data suggesting that there are a lot of breakthrough fungal infections in isavuconazole, Cresemba, but we would use, again, 100 milligrams,
And what's the dose with fluconazole?
200.
So Michael, I have a question for you. So I really appreciate your talking not only about what we can theoretically achieve, but really the differences between what we often try to achieve, either in models or perfect systems and then actually in practice, right? And I think you and I have had some good conversations about this. I was wondering about right now, how much, and again, seeing some of those curves that don't plateau, and it seems like they should plateau, how much of this today, and this is really an honest question, is related to compliance, and does, intermittent non-compliance, does it affect escape, or is this not an issue, and how do you handle that as a practitioner?
So for I think you're referring to TFR in CML patients.
Yeah.
I think that the real world is just less well controlled. So I guess one interpretation is that more people get on these trials who are not as well selected. So they have less PCR testing, it's less tight, they may have escaped a couple of times, but you don't see that if you do just a couple of PCRs every year. So I think that's potentially just a contamination, if you will, of the cohort with people who are not ideal candidates for a TFR attempt. And I mean, I don't think anybody is at grave danger because of that, except those people who drop off the radar and are then not seen anymore by anybody who treats CML or by any medical system.
Great, and I do have some questions from the virtual audience. Is NGS required or a must for all MDS patients for diagnosis, or can cytogenetics in fish be used?
Yeah, that's a good question. And I would say, look, I mean, if I were to say, no, I want to enforce NGS, this would be terrible for me to say, right? Because globally, every part of the world has their own challenges. But whenever and wherever possible, if we can get NGS in addition to cytogenetics, that should really be our standard of care, because as you can see, the way that we are informing our patients of their risk, the prognostic scoring system, the newer therapies, all rely on us having the knowledge of the somatic mutations. So definitely, I think if you can get it, please get it. Yeah. It could be a limited panel. It doesn't have to be an extensive workup, as long as the most important genes are captured. Yeah.
Mm-hmm. And then next question for you as well. You're very popular on the virtual audience here.
Okay.
We have many options in MDS algorithms for those with anemia. What are your recommendations for those with single lineage omitting red blood cell, such as thrombocytopenia with or without affecting white blood cells? What is your threshold for platelet value versus blasts, et cetera, when to start treatment? And please comment on TPO agents, HMA, and GCSF agents.
Yeah, this is a good question, and I think this is something I unfortunately, because of time, I left it out. But when we talk about cytopenias, thrombocytopenia also is an important issue in low-risk MDS, and in many times it occurs obviously along with anemia, but then you can see like isolated thrombocytopenia as well. In 2022, we actually published a trial. It was an investigator-initiated study looking at the combination of L-Thrombopag with lenalidomide. So this was actually for patients that had transfusion-dependent anemia as well as thrombocytopenia, and we found that actually this combination was very well tolerated. Some patients actually even got single-agent L-Thrombopag, which was well tolerated, and the theoretical issue that we have been encountering of does this sort of increase the blasts in the bone marrow or kind of hasten leukemic progression. We didn't see any of these issues in the trial. So I would say that TPO agents can be used. Eltrombopag is a better agent in MDS than romiplastim because it also stimulates trilineage hematopoiesis by affecting iron metabolism. So yes, I acknowledge that thrombocytopenia is an important issue with like more work to be done in this area. Yeah, but there have been many trials done even in Europe which show the safety of using eltrombopag. Yeah.
Great. And a couple more questions. Would you use luspatercept in all low-risk MDS for anemia or only those with greater than 15% ring sideroblasts?
Oh yeah, good question. If your insurance allows it, you could use it for everyone. I'm joking. No, but at this time I am using it mainly for patients that have, this SF3B1 with the refractory anemia with the ring sideroblast. The percentage of the ring sideroblast, yes, I know we say 15% and that's good. But even I would say like if they have sort of the morphologic phenotype and the ring sideroblast, I think you can consider using the drug. Yeah.
Mm-hmm. And finally, are epigenetic mutations included in NGS, and which ones are important if so?
Okay, yes, so most of the important epigenetic mutations that that are sort of like important in the pathophysiology of the disease are included in most like targeted myeloid panels. And the important ones that we obviously look at are ASXL1, TET2, DNMT3A, EZH2. These are the important ones, but they're generally captured in the myeloid panels.
That's great. Any further questions?
Are you using Ven as an induction therapy for are you using venetoclax upfront with AZA for all your high-risk MDS who are non-transplant candidates?
Not outside of a clinical trial. I mean, we are, at this time we are not using Ven as induction for high-risk MDS outside of a clinical trial. Perhaps, I don't know, Dr. Kadia, if you have different experience.
No, I mean, there may be some off-protocol use that we have, again, most of the clinical trial, but I think the second part of your question was the key, in patients who are not candidates for transplant. If they're not, then I typically won't use it, because I think that the benefit of adding venetoclax is to get those remissions, to get the CR rates or the blast percent down less than 5%, so they'll be better candidates for transplant. Otherwise, if they're older, unfit, not transplant candidates, you're just going to give them cytopenias and more transfusion. So I just typically, I may try some other investigational approach.
And another one over here.
I actually have two questions. So the first one was, yesterday we had a little bit of a conversation about detecting abnormalities in the peripheral blood. Obviously with MDS, our primary thing is doing the bone marrow biopsy, getting the NGS from there. Is there a role for peripheral blood testing, like an NGS panel, in that situation, especially if you're noticing progressive cytopenias and you don't want to be marrying these people every so often?
Absolutely, absolutely. So I will say that in my older patients that are, obviously more elderly and frail, I do a lot of peripheral blood NGS. The peripheral blood NGS can capture the mutational spectrum quite well. So in situations where you're not able to actually get a bone marrow aspirate to send for NGS, it's perfectly fine, okay, to use the peripheral blood. You may not capture accurately, say the amount of the clone expansion, like maybe your variant allele frequency may be a little bit lower in the blood, but as long as there are neutrophils and WBCs, you can capture a good amount of information from peripheral blood. Yeah.
And then my second question was, you had mentioned the prolonged time to transfusion dependence and using the low-dose lenalidomide for the 5Q. Mm-hmm. Aside from the imetelstat that you mentioned, any other drugs in that space that you would use in the non-del-5Q setting to prolong that time to transfusion dependence?
Yeah, so actually, I will say, although that trial was very interesting, right, it did show that time to transfusion dependence was prolonged. I don't know yet if it's prime time to actually start doing that, like giving daily lenalidomide dosing, just because as we talked about earlier, Dr. Fung mentioned this, lenalidomide can be a difficult drug, of course, there are other side effects, cytopenias, diarrhea, lots of issues. In this non-del-5Q population, right, I mean, I actually typically just do exactly as I told you, so more supportive care, ESAs, switching them around, myeloid growth factors, transfusion support, luspatercept if nothing works, and then lenalidomide. But we still have room for more drugs here. Yeah.
Thank you.
Thank you.
Maybe I'm just repeating myself, but please clarify your comment regarding the use of TPORAs for these high-risk MDS, which are non-transplant candidates. And the reason I'm asking is because we have very elderly patient population, and many of them are on these blood thinners from their cardiologists.
Yeah.
And my cardiology friends just don't understand what a platelet count of 15,000 means when they're taking Eliquis. And I said, dude, he's going to bleed.
Yeah.
I said, no, don't stop Eliquis.
Yeah.
I said, well, patient has to be alive to be on Eliquis. So agree. So how frequently use these TPO-RAs for these people who are non-transplant, have high-risk MDS, their blast count is more than 10%, because there were some studies showing up that TPO-RAs can also stimulate the blast count as well.
No, that's a good question. So actually what we were referring to in the online question was for low intermediate risk MDS. So where we feel like there is definitely a safety signal and it can be used without increased percentage of blast. There have been studies actually looking at using eltrombopag or some of these drugs even in higher risk MDS, but I don't think I advocate using it actually for high risk MDS patients. I would say that if they are high risk and they don't have like a donor available, I would go on to other investigational trials if they are available. I would not use eltrombopag. Yeah.
Everyone has a donor.
Exactly. I mean, you have lots of options now for donors, yeah, and also much better like conditioning regimens, post-transplant PSI, everything has changed transplant significantly. Yeah.
I have a question for Dr. Kadia. So this German transplant trial, randomized, aggressive versus string it out, is that practice changing? Do you think that's because I've always been struggling with what we do to some of these patients, trying to get them into some kind of remission and agonizing over the blast counts and whether it's enough now. And so can you comment on that?
Sure. Yeah, I think, on the surface, it's practice changing, right? You say, oh, well, you don't need to give these people salvage therapy. But the more and more we're discussing amongst our colleagues within the leukemia community as well as in the transplant community, because one of the frustrations we have is we'll get people down to 5% blast, 6% blast, and they say, hey, let's just take him to transplant. We don't have anything better. No, he's not in remission. You need to wait, get him into MRD negative. So now at least this helps us to push them and say, look, there's really no difference. I think that certainly it will empower more and more patients, more and more folks to go to transplant sooner if there are no good viable therapies available for them. And I think that the forest plot really kind of, for me, crystallized what's happening. It's those people who have this adverse karyotype, secondary AML, which is really not going to respond to salvage therapy. It's similar to the HMA failure folks, right? Those guys, they're not going to respond to any therapy. The best treatment for them is to move on to allogeneic, the best chance is to move on to allogeneic stem cell transplant. So I think in that way, it will help move people and convince them to move that. So I think so, and I think Krishna's going to yell at me.
No, I think we're on the same page. I was going to comment that, I'm pretending to be a lymphoma doc this weekend, but my first love is transplantation. So, Fred Applebaum had presented some beautiful data at a Tandem meeting years ago from when he was, he chaired for many years the SWOG Leukemia Committee. And they had actually gone back to patients who had failed multiple induction attempts and were considered refractory. And they had fallen off because they weren't followed anymore because they went off study, because they were taken off study because they were failures. And they went back and they found out a shocking number of these patients through, they did a query of, just Social Security death information, were alive. And he said, how can this be, right? These are patients who were, and this is not in the era of all the amazing modern agents you guys talked about. It was decades ago. And they went back and literally queried each individual, and they found out that a shocking number of these patients had apparently undergone allogeneic transplant. And Fred did not really understand why, because even at the Hutch, they wouldn't have transplanted these patients. But these patients clearly somehow got somebody to transplant them, and a number of them were actually alive, even though nobody would have reasonably, in any standard of care framework, taken them to transplant. So I do think, it's a different set of data, and obviously highly selected, retrospective data, but I think that this notion of kind of getting patients to perfection, and especially since we have now, again, the point of the 15 MMUD results that were published in the JCO, 1 year survival for patients with mismatch unrelated donors, right, who would have not even been considered for transplant at 1 year was 79% overall survival, right? So, I mean, we really have to think about transplant in a different way. I'm not saying that the indications for transplant are greater, but we routinely transplant individuals up to the age of 75. Everybody does have a donor now, and with reduced intensity conditioning, early mortality is low. Now, those patients with reduced intensity conditioning who are older often do have more relapse-associated mortality, but again, we can then get them back to smart people like TAP and Anatavi and just, do other things to try to get them in. But so I do think that this notion of, I think two things that are important, and I think we learned this at MD Anderson years ago, that crosstalk and communication. I mean, I was once involved with an advisory group on financial barriers, and less than 10% of patients that they looked at prospectively over a long period of time, all comers with acute leukemia, ever saw a transplant physician. Transplant, I mean, I'm sure Dr. Caddy and I would actually rarely disagree about who should go to transplant, but in many cases, in many places, there actually isn't enough crosstalk, and that crosstalk doesn't happen early enough. So I think that's probably one of the really smart, I think, important take-home lessons is just initiate the conversation, and we'll usually probably kind of tell you together. There are going to be times when we disagree, but I think we're probably going to be on the same page more often.
All right. Well, I want to extend a round of applause to our amazing speakers today, and thank the audience as well. I'm told lunch is ready, so Dalen's going to go.